welcome everybody. I got the most boring part of this entire presentation, so we will try to make it extremely slow, or extremely fast, because I don't want anybody going into a coma, while we're doing this. But there's a lot of work that goes into pulling one of these things together. It actually started in 2019, and we just finished publishing it this year. That's how much work goes into collecting the data and doing the analysis. But I wanted to start more with a story because it's really about you. A job task analysis is a collection of data, but the data is about the people that do the work. So what you're going to see today is a compilation of all of the important tasks that you do, the importance of those tasks, how frequently you do those tasks, and it's the understanding of what all that means pulled together and then turned into an actionable set of skills and work plans that employers or independents or wherever you work, it's applicable regardless of where you work. And all professions start this way. There are, of course, some other methods that you can use other than the specific psychometric analyses that we used, but essentially the steps of the process are the same. And that's the part that we're going to go right through right now. Okay, that's us. Okay, so this is the idea is we're going to outline the process, identify the components, and then Heidi is going to come up here and tie it all together and explain why all of what we're going to tell you is significant for the practice of patient and healthcare advocacy. Okay, so this is sort of what I just went over with you, and it's a very specific process. It is outlined by the various standard-setting bodies. Some of you are maybe familiar with ANSI standards. Some of you are familiar more with the NCCA standards. And anyway, they're all very much the same. And there are very specific steps you have to go through, and it is a descriptive assessment of the job-related tasks, competencies, knowledge, skills, and abilities that are required for an entry-level person to be deemed competent to perform a job. And that is across the board, regardless of what profession you happen to be in. So if you were a certified public accountant, somebody in historical time did a similar, and continues to do a similar process. Okay, the importance, and again, this goes back to what we mentioned earlier. So the exam, the BCPA exam, has to be built on the content that essentially represents, it's a sample of what you do. And the job task analysis is what informs all of the items on the exam. So it's obviously a sampling of all those items. Clearly if we had an item associated with every task statement or the knowledge, skills, and abilities, you'd be sitting in that exam room for a really long time. So it's a sampling, but the idea is that it's a representation of the collective exam that ensures that a person passes the exam, earns a credential, has demonstrated by a psychometrically valid and reliable examination process that they can or have obtained the core basic skills to perform the job. And that's what's really important about a certification. Certification is a voluntary credential that you earn. It's not required by law, it's not a licensure, but it's something that a professional individual wants to earn to demonstrate to the public, to their constituents or clients, whoever it is they represent, that they are competent and have gone this extra mile to earn the credential. Okay, so steps in the process, again, very briefly here. This is actually, this part of the paper is entirely written up. You can read the whole thing on the website. But there's a bunch of steps. You have an advisory group that comes together, then you have a subject matter group that comes together to identify the questions that are going to go on the analysis, and then those get vetted, and then you go through that process again, and then those get vetted, and then you put the quiz or the survey together, and then that gets vetted, and this takes like 2 years to go through this process. It's very, very lengthy, and I'm sure many of you participated in that process. We distribute it as widely as we can, want to get as many responses as possible. That's an interesting part that we'll talk about a little bit later, but it's very difficult to get people to complete one of these job task analyses. They're it's very comprehensive, but it's only useful if you have complete and reliable data, and that is part of the whole statistical analysis. So then, of course, we go through the data analysis. We have to go through all the validations to make sure it has to pass all these statistical tests. And so that was this, as you can tell, this was my part of the job. I got to do all the nerdy stuff. We did have some challenges. We had a lower response rate than we had hoped. But fortunately, because we're a new profession, there are some various guidelines that we were able to follow, and we fit neatly, within the guidelines of what would be considered an acceptable population of respondents, and so it all worked out. Everything worked out, but it was quite a challenge. I'd be more than happy to talk to any other fellow nerds about this, but the rest of you just happy to know that it worked. Is this am I doing this slide, Rebecca, or is this? Okay, this is mine. Well, I didn't want to get into her stuff because she's got some really good stuff. So the major insights, again, that we were able to make some very significant and substantial insights and improvements in the process. I sort of already went over a whole lot of that, and I'm not going to repeat it. We identified not only, so the original job, we didn't have a formal job task analysis. I guess this would be like my wrap-up final here. Because when patient advocacy, or the PACB, whatever it was called back in 2012, started, it was, there was not a profession established. And so they didn't have a job task analysis study or hard data to actually use. And so the only way you can do that at the very beginning, when there isn't any, is you crowdsource the data. And so they did formalize the organization, they crowdsourced the data, came up with the original domains. There were 7 domains at that time, and the essential task statements. And what you'll find, Heidi will get into this in much more detail, but the initial task statements and the overarching domains, those were pretty much the key elements that comprised the original domains of practice for advocacy. But what we recognized as we went through this process was that there was a lot of detail that wasn't that it was left out, it just wasn't clearly articulated. And so that's the part where we were able to really begin to start teasing out and reorganizing it in a way that made a lot more sense. The exciting thing that you have to conclude with as a nerd is that we had a very high reliability coefficient, which meant that there was a broad agreement across the board. Everybody that participated in the process agreed that what we had presented them and how they had responded, that there was agreement across the board. And so everybody, we had great confidence in the data that we were able to use. So I'm going to wrap now and pass it on to Rebecca, but this is where it's really important to understand. So I pulled all this data, and again, this was my part, and I had spreadsheets and spreadsheets and spreadsheets and spreadsheets, and they told me a lot, and I really tried hard to make the data tell us exactly what we needed to do. And it did. I mean, it told us a lot, like it's supposed to. But there was some element that wasn't quite right, something I was missing. And so one day, we were having a board meeting, we were talking about it, and I was expressing my frustration that I had like turned these things every which way I could turn them and run every statistical report I could think of, but I was missing something. And Rebecca, in her quiet way, raised her hand and said, well, I would like to see if I could participate in this. I will volunteer. And so Rebecca, in her quiet, wonderful, also sort of nerdy way, came in and spent a few weeks looking at it. And she came back and said, well, here is the solution. Here is the answer. I figured it out. What do you think? And Heidi and I both listened to her and said, well, darn, yeah. We were so excited and astounded that she'd come up with this brilliant way of it wasn't different, it was just repackaged in a way that made sense. And it pulled out those missing parts. So I am going to pass it now to my esteemed colleague, Rebecca Green, who will get into the more fun parts of what we learned, and then she will pass it on to Heidi, and then Heidi will tell us about what it means for us as a practice going forward and moving more towards a professionalized view of patient and healthcare advocacy.
So Danielle is right. I am nerdy. I don't know which of us is more nerdy, but I found this to be one of the most exciting things I've done in a long time. So I'm a registered nurse. Been in that profession for a lot of years, and I don't want to take up too much time with this, but anybody who's in healthcare kind of may know that nursing sort of went through this sort of revolution of professionalization starting back maybe in the 60s, but also 50s, 60s, 70s, it became professionalized. And so I went to nursing school just as all that information had come to fruition and was being integrated into a bachelor's level, right? Which is where it all started for nursing. And so what excited me about this project was I felt like I was I could be a part of theory building for building a burgeoning profession, which is so much needed in our healthcare system today. So for me, this was super exciting. Maybe not for y'all, but so I'm just going to tell you a little bit about what I did. I'm a qualitative researcher, and so for me, this was like taking the pieces of the data puzzle and putting them together. So really enjoyed every moment of it. So Danielle has already talked a little bit about the rationale for the revision. We want to continue to grow the profession, refine knowledge associated with the profession, and create a deeper understanding and more specific competencies related to what advocates do. That is part of professionalism. And so we, as Danielle so eloquently described, we based what we did on previous knowledge, which came from the original start of the board. We brought in the new evidence that came from the survey that Danielle and others, many others participated in and created some new evidence. And then we had to kind of deconstruct everything. So we had to deconstruct what we had assumed before. We had to break the pieces back down from the old knowledge and sort of mix it up like a jigsaw puzzle with the new pieces so that we could come up with a whole that was a new picture, so to speak, of what we have learned in the ensuing years and what we gathered from our survey. So part of what was missing was some definitions. So there were some domains that had been established before, but there was missing sort of the definitions of what those domains represented. And so we felt like that was an important part to build. So we have these domains, but what is that and what does it mean? So we built some definitions. The other thing that was missing is while we had some maybe what were termed competencies, they sort of were a mishmash of a bunch of different things that didn't really fit the definition of what a competency is. And so we thought, okay, we've got these knowledge, skills, and abilities, and we've got tasks, but what was sort of missing was that next layer of framework, which was competencies and competency categories. So we let the data speak to us and tell us, what are the definitions of these domains? What are these competency categories? How do you put these things together in a way that makes sense? Group them. So we realigned, we integrated the old with the new. We revised some terminology that was somewhat dated and somewhat redundant and sometimes contradictory. And so we did that as part of an iterative process in which we bounced things off. Okay, so we're going to change this terminology a little bit. What do y'all think about that? And so that was a piece of this process for updating as well. So I'm not going to spend a lot of boring time on telling y'all about the pyramid of domains, competencies, tasks, knowledge, skills, and abilities. Simply know that the domains are at the top. The competency statements come next. The task statements come next. And then what undergirds the task statements are the knowledge, skills, and abilities that you need to be able to do those tasks. That's how it works. And then underlying all of that is the body of evidence, which comes not only from our study, but also from the greater body of healthcare evidence that already exists, that we share with so many other professions. So that is sort of the theoretical framework and how it looks. And I'm not going to read you all those little definitions, although I'd like to. Trust me that if you follow the link to the job task analysis, it's all in there. I think it's 42 pages, something like that. So our revised domains of practice were collapsed. And you know what, y'all? I brought my little notes up here, and I haven't looked at them one time, but I'm going to now. So the domains in general were collapsed from 7 down to 5. And we did that simply because that's what the data told us to do. The data told us that that made more sense because there were so many overlapping things that were in different places that really needed to be together. So our new domains are scope of practice, empowerment, autonomy, rights, and equity, communication and interpersonal relationships, health, medicine, and the healthcare system. In other words, knowledge and understanding of those things and how they work together. And then finally, professionalism and ethics. So one reason we had to do a collapse is because the code of ethics for advocates was added later in the world of patient advocacy. And so it was this little thing just dangling off by itself. Well, we all know that ethics undergirds and underlies everything. And so we thought that it made sense to put professionalism and ethics together. And that's what the data suggested as well. So the next thing that we had to consider was this thing that was sort of missing. It had been missing. So you all know, probably in your reading and understanding of the world, you've probably heard of the determinants of health. And they have to do with being it's client-centered, right? The client's at the center of everything. But there are many other things that affect the client, the advocate, and that relationship within the healthcare system. And these were not created by us. This was a piece of another theory that we borrowed that makes sense in the work that we do. And we're not the only ones, right? Nurses, doctors. There are many professions that incorporate an understanding of the determinants of health into their competencies, proficiencies, and understandings. So we put the client at the center, and there are these contextual variables: neighborhood and environment, healthcare access and quality, economic stability, social and community context, education, access, and quality. Those are all things that affect how someone is or is not healthy in this world. It affects how we are as professionals. It affects our relationship as a whole with not only the client or patient, but also with the other members of the healthcare team and society as a whole. So again, I could talk all day about the determinants of health, but I don't have time to do that. So I know y'all are sorry about that. Okay, so this is just an overview. Again, this is sort of an outline of what you will find in the job task analysis. So we're talking about the job task analysis, but what we need y'all to do is go read the job task analysis, because we can't possibly cover it all here. So at the top again are the domains, which I've already elaborated on. The competencies are categorized within the domains. So under every domain, there are a set of competencies that organize the tasks that you do in that competency category, undergirded by the knowledge, skills, and abilities to do those particular tasks. We also pulled qualitative exemplars from the data that the participants sent in. So people had the opportunity to free text, how they did this work in the real world. And so we pulled those statements to kind of illustrate, to give a picture illustration, if you will, of exactly what we were talking about. Then there are the tasks. These are applied work activities. These are the things you do day to day that you can write down. Okay, I did this, I did that, I did the other. And then finally come the knowledge, skills, and abilities that support that work. The knowledge, skills, and abilities and the tasks are sometimes a little bit, they can apply in more than one category, and we tried to reflect that in the way we designed the information to present to you, so that you could look at a task and you could say, oh, well, I would need a variety of knowledge, skills, and abilities to be able to do that one task. And so we have created a visual that will help you see how that works. So the next step was to come up with another thing that we thought was missing, which was a model or a visual representation of this theoretical framework that we built. And so this is beautiful. We did a lot of negotiating and just sort of refining, and it was truly a group effort, this thing. So it is client-centered, as you see, similar to what you see when you look at the social determinants of health model. We use the spokes of the wheel to illustrate those contextual variables that affect the relationship, and we equally divide the domains. They're all important, they're cyclical, they're all happening at the same time, and you can't say that one is more or less important than the other. So this is the visual representation of that. And one last just sort of closure for me. So the model, if you go to the job task analysis, you will see how the model, the visual model, and the framework are integrated. We took our existing knowledge and the new data, and that informed the theoretical framework. The new framework informed the development of this graphic or this visual model. And we were able to use this to kind of close some of those gaps that we identified in this iterative process that took 5 years. And that was just the whole idea of client-centeredness and those contextual variables. It was assumed, right? But it needed to be stated, and it needed to be a really visual part of what we present to the public as what it is that we do. It's not just a profession. It's about that person right in the center, right, and their life. That's what it's about. So I think that's my last one. Yes, and now it's Heidi's turn to tell you what this means for this point forward. That's right.
First of all, I'd like to start by saying that the PAC board is unbelievably blessed to have the expertise, energy, and nerdiness of Rebecca and Danielle, that we were able to do this in-house. And if you think this is dry, it's been a very long process, and we are very, very glad that we're at this step. And we just hope that some of the enthusiasm that we have after this can be shared with you. And I do hope that some of you really look at the report, because it is amazing what came together there. And again, I can't thank them enough for doing it. So anyway, so what does it all mean? Well, it has a lot of implications for instance, on the employer side, hiring and recruitment, right? It can give you very accurate job descriptions. It can tell you what competencies and qualifications are necessary for certain jobs or professions. Training and development. It can point out areas where somebody is lacking expertise and maybe needs a little bit more help or some extra training. It can help with performance evaluations, right? Knowing what defined criteria are, is that person meeting these criteria? And you want to have a certain set of standards, and it's all laid out, and are people meeting these standards? Role clarity, which I think is incredibly important and something I know we all struggle with in this sense, because there's a lot of overlap with other professionals in the healthcare system in what we do. And so it's really important that we have our role defined, and I'm going to get back to that later. So for policymakers, well, we live and breathe this, right? The standards and certification body is based on these JTAs, and that's what helps us guarantee or safeguard a certain level of competency across the years. It assists in crafting regulations, ensuring that advocates have the qualifications and adhere to ethical standards. As all of you know, ethics is the largest component or professionalism in ethics, as we call it now, is the largest component on the exam. So for policymakers, workforce planning, right? What are the skills that people need to fulfill these jobs and fill these jobs? Where do we need to put resources to make this happen? And finally, public trust to us is incredibly important, and we feel if the public can see that these are the things that patient advocates, healthcare advocates do, it's all delineated, it's out there, that gives you a sense of trust, right? Examples of how policy and advocacy is informed are, for instance, some of you may have already filled out an ONET volunteer form. The Department of Labor puts out a listing of all professions, right? And they have all little definitions of what these professions are. And healthcare advocates fall under the broad rubric of patient representative. Now, we all feel that what we do, while there is overlap with other roles, no question, that it is distinctly different enough that we would like healthcare and patient advocates to have a separate ONET code, right? And these are codes that employers look at, human resources people look at, college recruiters look at, high school counselors look at. I mean, it's not trivial. In order to get this process going, though, we need to have at least 100 volunteers who fill out these forms. And I won't make any bones about it. There's work involved in that, because it is similar to the job task analysis. If they pick you as a volunteer, you can sign up, and if they choose you, they will be asking you a lot of questions, and they will really be asking you how much of your time do you spend on this, et cetera, what are the kind of things that you do. But we feel it is critically important to do that, and because of that, we actually have some ONET volunteer sign-up forms right here that you can pick up later if you would, and otherwise if you don't make it today, please come by the Chicago booth and pick it up there. It would be huge if we can get this done. It takes a while, of course, but if we could get this started, I think it would be really, really important. Insurance codes. We heard a lot about insurance codes this morning, and I will take the speaker's prerogative and tell you that when I first started, first of all, I didn't start doing advocacy as a business until I discovered that there was a certification for it. I was a physician, an anesthesiologist, critical care physician, I've been advocating for decades, but it never occurred to me to do it as a business until I saw that there was a certification. Because to me, if I'm somewhere accompanying a client to a physician's office, I'm not there as a physician. I'm not there as a public health person. I'm there as an advocate and should have the requisite certification to show that. So when I first started, I also agreed. I said, we don't really want insurance codes. That's terrible from the healthcare field. You know, we know what a pain in the butt that is. So once I started doing it, though, it's clear our society will always be at least two-tier. We are always going to have people who can afford to pay out of pocket for advocacy services. Let's make no mistake about that. On the other hand, a lot of us do a lot of pro bono work. And while that is great, and serving people who otherwise can't afford it is wonderful, if you think of the professional aspect, and what we are ultimately trying to do is grow the profession, right? Is if you don't assign a dollar value to something, in our society, it doesn't mean anything. And so doing pro bono work alone is, well, yeah, great, sure, I can get something for free. And the fact is, we all know that the people who most need our services usually can't afford them. And so I am in favor of insurance codes. I am in favor of enabling as many people as possible to get healthcare advocacy services. My concern is having a competent pipeline of the numbers of advocates needed to fulfill these services. And finally, another example is, some of you, I'm sure that you're aware that there's been an effort to form a national patient safety board. And next month, I think there are all sorts of things, no, this month, coming up. So if you haven't looked into that or signed on to that yet, I would also encourage you to do that. So what does this mean for us, basically, as practicing professionals? Well, if you really go and look at the job task analysis, it provides a bit of a roadmap, right, for what and again, it's very, very comprehensive. Nobody expects everybody to be proficient in every single one of the statements that are there, but we would like you to know about it, right? So it's one thing to know about something and at least say, yeah, that rings a bell, or be proficient in it. Again, clarifying roles, right? Really, really important to clarify what is expected of you, what can be expected, what are the things that you need to know about. Career advancement, right? You can look at the job task analysis and say, oh, interesting, these are skills that I haven't achieved yet, but this sounds interesting. Maybe I'll try to get continuing education or go get additional training or work with somebody, get mentored in a particular area where you may not be proficient at the time. Job satisfaction. I do believe that the greater the definition of a role and the expectations are, whether it's in your contract, in our contracts, we specify a scope of service that we are going to provide. Right? And we do that not just for us, so we know what is expected, but we do that for the clients so that they know exactly what is expected. So, and I believe that really enhances job satisfaction. Finally, this is one thing we don't really want to think about so much, namely that you have to do this every 5 to 7 years. I don't know where we're going to be in 5 years, but this is a living, breathing document, because as technology is changing. What we do today may look very different from what we're doing even in 5 years. For some of you who saw the pitch yesterday, there's all sorts of stuff coming down the pike that may enhance our services, may complicate our services, we don't know. So the roles of the profession are constantly changing. And so in order to have a robust certification exam, you need to really be asking the questions that are relevant for the current practice. And that's why it's done every 5 to 7 years. And basically, the image says it all, right? It's all about trying to make things better. So vision in terms of future, this is a picture of the cover of a industry insights report from this year about global patient advocate solutions market forecast for the next 7 years. And it's not so much what's in the report, which shows that globally patient advocacy services are projected to grow considerably over double digits. It's the fact that somebody commissioned it in the first place, right? It takes a lot of money to do these reports, and the companies that do these reports sell them for a lot of money, right? So whoever decided to do this, that is a testament to our profession, to the fact that awareness is growing, awareness of need is growing. And that, to me, was the most significant thing about this report showing up. However, as I mentioned before, my greatest concern, we all know about the need. My greatest concern is having a reliable pipeline of competent advocates. And in order to do that, we really need to build more training and educational curricula. And it is something that PAC board, the leaders in the Coalition of Healthcare Advocacy Organization are working on. We're collaborating with other individuals and organizations to try to upscale curricula for healthcare advocacy services as soon as possible. We need to strengthen our communities through organizations, and we're doing that, right? And lastly, work collaboratively. That's what HAS is all about, right? We're here. This is really a big amalgam of people who do a variety of jobs, but we are all essentially healthcare advocates and patient advocates. So I'll leave you with a futuristic view. We all know that we bridge gaps in healthcare access and within the system. We still are working toward being more formally recognized and truly valued as a profession. But we've made great strides, really seriously, just in the last 5 years. We know that we are part and parcel to helping with equitable access or more equitable access, that we help provide more patient-centered delivery. And finally, we all would like more easily obtainable and sustainable health and wellness for everybody. And with that, I will leave you with the link for the download. I warn you, don't print it out, it's pretty long. And we're happy to take questions. You two, can you join us?
And I just
Thank
want
you.
to say, because I was part of the grassroots effort to get a credential started, I am so appreciative and so excited that we have this. So thank you guys so much for all the work. It's a lot of work. So. Anybody have questions?
No? Really?
I don't know if you can answer this directly, but I'm a clinician and I'm just interested in transitioning into the patient advocacy space and taking the certification. What curriculum might you recommend for people who are interested in pursuing the field, if you may speak to that?
Well, that is part of it. We hope to be able to broaden the offering of curricula and training program. At the moment, there are certainly some that are, Cleveland State, I think, in Florida, there's some. There are a variety. I think the ones that are available are on our website. There are also sort of, building blocks of advocacy programs that various, so AFA does something, so the Alliance of Professional Health Advocates, and I know the Bridge has sort of a program. They combine, some of it is more of the business of advocacy, not necessarily really the maybe bread and butter. There's some mentorship programs that I know NAC is trying to do. They're not as many. I mean, you can see how hard it is for me to answer that, and that's not to diminish what is there. It's just to say it's not enough. We need to make greater access. And what we found is that people tend to come to this not just from personal experience, right? But usually mid-career, right? They finished raising their kids, or they're kind of burned out from what they're doing, but they still they have all this expertise and they want to help. And they find that, wow, this is something where you can really make a huge difference. Right? We all know it's true. But that we are trying to get to community colleges, to adult education institutions, to get curricula that are put together through subject matter experts of people in this room who determine these are the things. And a job task analysis is the first thing you do to establish a curriculum like that, because you have a roadmap. And so I can't tell you how soon it's going to happen, but we are really working very, very hard to make it happen. And if anybody has just over $1 million is kind of what we need to get this launched, we're happy to discuss it, but it's just seed money. But I'm sorry, I can't be more helpful.
There are some resources that are available online that are part of our package of sort of study materials. There's a practice exam and there's some other things, but there are links to evidence-based resources literally associated with all the competencies. And so there are ways, if you're really willing to dig into the resources associated with that job task analysis, you will find the evidence to support all the things that we've got in there. And so there are articles that will be referenced about determinants of health and all these other things. So if you really dig into it, you'll be able to self-educate a great deal to sort of maybe identify where you might need to beef up your self-study, if that makes sense.
Just to piggyback off that, I agree with what you just said, because the material that's on the Patient Advocate Certification Board is what we're all using to develop courses. It just takes what they have and kind of explains it. So if you can take that and read it and look at it from a clinical, from your practice standpoint, I think you'll be able to use it to educate yourself as you move into this. So I think it's there. This has been great. And I echo what Beth said about, I was on the founding board too, and we have come so far. And I really did in my, on social media during this conference, and thank Jerry Hollenbach, who was one of the people who, in the very beginning, put the job analysis together, because we didn't have $10,000 to spend either. But now that the board did this with the data, with the survey, with Danielle, you are up there, unbelievable to
Yes.
really. So much has happened over the past 12 years that we are further than we ever were, and it's because of the dedication to this. So thank you.
And I will just, no, go ahead.
One question, what is that safety? You said a National Patient Safety.
National Patient Safety Board. It's supposed to be sort of analogous to the National Transportation Safety Board. So I know that Brad is very involved in it. There's some other, yeah. Oh, yeah, actually, I think Karen might know something about it too. Okay, Karen's sitting back. I just want to add to that briefly, and the new materials that especially Danielle pulled together and Rebecca pulled together, things from the JTA, it is so much more detailed than any of us who were in the first cohort of taking this exam. We're like, this really spells it out and explains it. So I think people will find it a lot easier to prepare and really know what the expectation is.
Hello. So I just want to commend you for what you're doing, but I have a question. First of all, on the subject of curriculum and study. So what I want to tell you is that 12 years ago, as a kind of a interest, I had an interest in going into this profession, didn't even know that it existed. I live in the Chicagoland area. Didn't know about Brad because he wasn't involved with this 12 years ago. I had met someone named Terry Dreher. You know Terry. Having said that, I said, gee, I really want to do this. I have an MSW that I had gotten in 1974. I look around the room, I see people here that are younger than my youngest children. I don't see too many people who could say that they're great-grandfathers, which I am. So I'm at the twilight at the end. But at the beginning, there was no BCPA, there was none of it. So I spent $6,500. And I went to a program online which for me was very difficult. I didn't even know what an iPad was. And I took this program at UCLA. It was an incredibly demanding program. It took a year and a half. And I got a graduate certificate from them. Fast forward, I've now been doing this very part-time for 10 to 12 years. I have my own specialties, my own interests, and so on and so forth. And so here's the question that I'd like you to answer for me, having given you that background. I had a discussion with somebody, and they said to me, you have no business being in this profession if you don't have the BCPA. And my response to the person was the following. There are people who have BCPAs who have no training, no background, no experience, but they signed up to get a BCPA. I know of such people. I've been doing this for 12 years, and I tried to take the test in the very early years, and I had a problem with it because there was dust in the room, it was a building, they were hammering away, and I couldn't hear it, and I got up and walked out, and I almost passed the test by 2 points. And I said when I walked out of there, this is ridiculous, and I've not had the motivation now, at age 73, to go back and take that test. I don't need it. But I want you to give me some sense of assurance that I'm not less qualified to do this than somebody who has a BCPA. I need to understand that.
Well, I'm not saying that you're less qualified to do it. There are a lot of people out there who have been doing this for a long time and are very, very experienced, and who we ask and we bring in as subject matter experts to help us refine, the curriculum, et cetera. So that's not necessarily the point. The point I was trying to make before about having a requisite certification is that what we hear a lot is, oh, I have so many letters behind my name, I don't need that. And that's where my point is, well, if you're starting out in a business and, this is what you say you want to do, that we would recommend doing it. And it's a commitment to the profession itself and to your own professionalism. I'm not suggesting, there are a lot of people who took it initially, I think, who had been in the profession for quite a while, and they took it just to show that they could or they wanted to, and they've since sort of retired. So there's this whole group of, because as we know, the demographic for the most part is middle to elderly, and that too is something we need to change and try to change. And we would like, this is hard, what we hear a lot is, I took care of my aunt for 4 months, and I realized how hard it was to navigate the system, and now I'm a patient advocate. Not really, right? And that's also the exam when people say, well, I've been doing this, I should pass this, I shouldn't even have to take this, there's no way that I could fail this. Well, you have to know some stuff if you're going to do this. And so we take our obligation and responsibility toward the public, patients, and other advocates for that matter, very seriously in wanting to provide as competent a service as possible. And this is the certification is the way to show that. It's part of the public trust. And I would never say that you're not capable of doing it. We don't exclude people for not being BCPAs.
Heidi, Rebecca, Danielle, I really appreciate everything that you guys have done for us. As BCPAs, what is your ask from us? What can we do to help build this profession, get the word out? What is your ask to us?
Well, thanks for the question, Michelle. One is, in fact, really these ONET. Volunteer to be an ONET subject matter expert. That's one thing. Getting our own listing is really important. If people approach you about the needs for the profession, we need more of us. We need more of us. And so it's really, again, putting resources in the direction of training and curricula and really making sure that people know what they're doing and not just hanging out a shingle.
And I would like to add just one little thing to speak to both of you who just asked questions. We're at this pivotal point where this can really become a profession, its own distinct thing. And so for people who've been practicing, whether they're certified or not, who are truly experts in this work, just embrace the professionalization, and whether or not certification exams are fair, just that's a whole nother topic. And I speak as a nurse, right? There are lots of great nurses who have to take those board exams a gazillion times before they finally pass it. No reflection on anyone's ability. This is just one more step. And so if you love the work and you love the profession, then even if you don't want to become certified, join us in moving it in that direction. And we believe that certification is just an essential component of uplifting it and making it a professional. And so help us with that, and we would welcome you in any way, shape, or form.
Hi, I'd like to ask a question as it relates to the ONET codes. Oh, I'm sorry. Is that better? I'd like to ask a question as it relates to the ONET codes. I'm a certified community health worker and a healthcare consultant. I've worked very closely with patient advocates. And what I do now is often connecting advocates to roundtables with CMS. And often I've heard things come up about patient advocates and the need for expansion in terms of coverage as them, to be able to get paid for what they do. And so my question to you is, do you help to connect advocates or have insights on connecting advocates to those kinds of opportunities? As kind of background, it's a bit of a limitation in terms of the work that I do, and I think that that kind of voice could really make an impact, and actually, getting in front of CMS lead you to your goals. So that's my question.
Well, we're starting, yes, no question, couldn't agree with you more. Another rather large organization that we are working with is the VA and the DoD. So that's, another whole patient population that needs help and needs services. And we're dancing as fast as we can, and we're an all-volunteer board. And so right now, we're just glad this is done. I think we're at time. I don't know. Oh, okay. We're fine. I'm fine. Okay.
Quick question regarding quick question just regarding the topic of advocacy services being covered by insurance. And would you envision, should this unfold, that probably Medicare would take the lead and then other private carriers would fall would subsequently pick it up, or what kind of
Yeah,
strategy would you?
so the one thing that was not mentioned this morning in the Solace presentation, one of the things that was not mentioned is that the codes that were created are incident to codes, right? So these aren't codes that refer only to the advocate. They actually need to be ordered by a physician or an allied health professional who is certified with or licensed with Medicare. So it's not the advocate who's applying for it. You have to go through a physician, and theoretically the physician is really the nexus there. So that's one thing. But I'm losing my train of thought. What was I talking about?
Billing, coding, will other
Yeah, so what I do believe will happen, and I disagree a little bit with Jeremy on that in terms of employers and companies, because this is about the Benjamins, right? And they have already realized the personal navigation services for their employees cut down their costs in healthcare. And guess what? Their employees are happier too, because the outcomes are better. Resource utilization tends to be less because, oh my gosh, they now understand their diagnosis. They understand what their options are, and they may actually not want a certain service. When they get discharged from the hospital, they understand the post-discharge instructions. They don't bounce back. So all those things, this is a marketplace, and healthcare clearly is a business. And so it will be business-driven, and it will come from, in my opinion, more the employers that do it for their own organizations, and that data is already out there and starting to come out in terms of the cost effectiveness, that it doesn't just make sense, it makes sense, CENTS.
Hi, my name is Carol Lale. I work within the military health system. I'm a patient advocate at an Army Medical Center in Washington State. And when I look at this certification, what it tells me is that in the military environment, what we do is quite a bit different than what you see in the commercial, in the civilian world. And so the certification to me presents me as being more well-rounded, because I may not know a lot about it, but I've studied a lot of the different domains and everything. And so to me, certification tells somebody, and I am hoping to transition once I retire from the military, what that certification tells me is that I can present myself in the civilian community as somebody who has at least a groundwork in the different domains that are represented by the certification. It doesn't mean that I'm any less qualified before the certification or after the certification. It just kind of gives people a view into the things that they can expect me to know about. So that's why I believe the certification is so important.
Thank you, Carol. We recognize that, of course, the military is a completely different patient population, and that's why we are working on a military subspecialty exam, right? Designated or directed to DoD and VA advocates. Go ahead.
I just wanted to make a couple of points about the certification. First, I've been a research patient advocate for over 5 years. I was trained by the University of Texas Southwestern, as well as Susan G. Komen Advocates in Science, and I went through Lynn Sage, and I did the Dana-Farber equivalent of it, which is part of Harvard last year. And I took the exam and I passed it because I had all this formal training from these university hospitals. I am not a clinician. I've never been a clinician. I am the survivor of multiple rare diseases. One of which was a type of breast cancer that did not have its own protocol, and now at least UT Southwestern has one because of my research that I presented to them. But there are two things that were brought up that really hit home for me. One is I was volunteered as a research patient advocate. And as soon as I was able to announce to UT Southwestern that their research advocacy program, which is what, there's a whole team of us that have been sent through this formal training, UT Southwestern RAP now has a board-certified patient advocate. Yeah. I now, the very first thing that they said is one of the research physicians said, "Oh, great, I have 2 DoD apps that I need your lay abstract and your letter of support from." Because the Fed has now tied patient advocacy to grant funding. And some grants, including Susan G. Komen, are not going to get approved without a patient advocate on that grant application. So that's what I've been doing kind of for the last 5 years. So this physician that reached out to me and said, great, I have 2 DODs. I had done one for her and had no idea what her research was doing. And I said, you know, the thing about it is the patient advocate is supposed to be engaged for more than just support for your grant application. We are to represent the patient voice during your clinical research. Mm-hmm. And I did that on your first application. And if Susan G. Komen were to ask me what the status of your research is, I would have no clue because they didn't engage me beyond what they needed to get their money. And I said, and oh, by the way, my new rate is $150 an hour. And they threw up all over that and gave me $100 an hour. And there is value, and anybody who's in marketing, which I'm not, but anybody who's been in marketing knows that price point, there's a value proposition there where people think that if it's more expensive, it must be more valuable. And that is absolutely the truth as that goes. The next thing that happened is Dr. Artiga is the head of the Simmons Cancer Center. He is the executive director over at UT Southwestern. I got an invitation to his lab, and I am now getting $100 an hour, and I'm on his mentoring committee for his research analysts there. Now, there's not many hours here. We're talking like monthly meetings. Woo, $1,200. But it's the premise, and it's the certification that got me there. And the second thing I wanted to say is I don't know how long ago it was that he took the exam and didn't get feedback or the results he expected. I will say that when I took the exam, the results are broken down by where the competencies are. And I did really, really well in most of them. And then I have this area that says, score indicates more knowledge needed. So now I know where to go and focus. Even though I passed it, I still have work to do. And it told me where.
Yeah, thank you.
Yeah. Yes, thank you, everyone. I think everybody wants to go to lunch, so thanks, Heidi, Rebecca, Danielle.